I do want to do a one case presentation and get both of your opinions on it. He happens to be a patient of mine. When he was 58 and in 2010, he was diagnosed with a Gleason 7 prostate cancer, clinically localized, and had a PSA of 3, and had a robotically assisted laparoscopic prostatectomy to undetectable PSA. And approximately 2 years later, his PSA rose to 0.11. And after consultation with some very well-known radiation oncologists elected to undergo radiation therapy at that point, achieved an undetectable PSA at less than 0.03, and has been staying at that number until approximately 2016, when it went from less than 0.03 to 0.03 to 0.05 in 2017, 0.08 2018, 0.13 2019, and 0.19 in this year, and one about a week ago was 0.29. So we've actually talked about him in the past together with both of you. And so I'm wondering, at this point in time, what are the options, either in trials, staging and imaging, since we just talked about how the Axeman scan is questionable value with PSAs at 0.2, and what are the options as far as systemic treatment for this that would be reasonably non-toxic? We've talked about those oral anti-androgens, which we think have great promise, but I don't believe they're approved for this at this point in time for someone like him. So what would each of you do with an individual like this if you were trying to optimize their care? Would you intervene now, or would you just still continue to watch the PSA go up as long as they're comfortable with it? And when would you institute diagnostic and/or treatment options?
It's a really frustrating place to be, I think. I'm always happy when I hear a long-term story, of, hey, I've had this many years ago and here's where I am. But I also recognize and respect that it's a long-term story, and people. This would happen to all three of us, where you just sort of want it done. Why is this not done? Why am I still dealing with it? So I totally understand that. I think the quest now, in some sense, is to find out where it is. And you're right, Michael. We could continue to do all sorts of scans and still probably have difficulty in identifying it. I can tell you from our current trial that we have with PSMA testing that he would fit that criteria as a person that has a detectable value, has had surgery and radiation, and then it's the where is it. So I think many people around the country would say some sort of PET testing would be indicated. I agree with Jason that if you can do that even without having traditional scans, which probably won't pick up anything, it would probably be the right next step. And most of the testing is basically a one-time, you show up, you literally just get the test, and then there's a result that's given, and that's it. So it's a different trial. People hear trials and they think, oh boy, it's complicated with, treatment and all of these blood works. No, that's a treatment trial. This is an imaging trial. So it's still a trial because we don't know the answer, but it's important. And I think to Jason's point, PSMA PET, which is attached to a gallium-68, which is just, all that means is that's the imaging version, not the treatment version, was just approved, but only for centers at UCSF and UCLA. So we're not there yet globally, but it's an exciting step because it's a recognition from the regulatory bodies like, oh, okay, well, PSMA might be a viable actual tracer. And that's a step in the right direction. So that to me is a big win. But you and I and the average physician, or so if you're not at those centers, you're not going to be able to still order them. It's still going to be a challenge. So I think doing it on a trial might be the next step.
Thank you. Thank you. I agree with you, Elizabeth. And that's one of the benefits of these partnerships is, a patient like this, I would, email, text Elizabeth and say, I got this, tricky situation, can we get him on your PSMA trial? And reaching out, and it's a collaboration between community urology, and reaching out to an NCI designated cancer center. And that's the beauty that we have in Michigan. We have such great relationships with all our academic and community sites, whether it's relationships through the foundation. We have a statewide collaborative called Music. We work closely with University of Michigan. 90% of the urologists are involved in this. And I think it's, reaching out, and we're in a very collegial environment where, I can text Elizabeth in 2 seconds, yeah, send me the patient's name, we'll get them on the trial. And it's being resourceful. There's options out there, but using your connections or your relationships, and we work together to solve the problems, because we know things are moving so quickly. Elizabeth, frequently will get a trial and that no one else has right now, and then we'll say, Elizabeth, I got this patient's got a CDK12 mutation. You got your trial? Yeah, good. And we work together like that. So I think that's key. I agree. Getting back to Michael's case, though, I think, yeah, PET imaging is critical. The higher the quality of imaging, can we find it? But we're still frustrated. This is 20-year-old questions or problems that we keep running into. If in this case the PET imaging was negative, we do the best we can to find the cancer. I would, watch the PSA, and I don't have a clinical trial for this space. I would probably reach out to Elizabeth or, University of Michigan or, any of the sites and say, do you guys have a trial for made negative? And say, if they don't, then standard of care is we close surveillance. And once the patient does develop metastasis, if he does, and then we do have great therapies and treatments to offer the patient. But fortunately, it's a frustrating space in our continuum of care. But again, I think it's working with the resources we have and the way we're set up. We got to reach across health systems, reach across specialties to work together to do what's best for the patient.
So just a quick question supplement to that is, how close do you think we are to PSMA type scan for imaging being linked to a treatment molecule to treat those oligometastatic foci within the body?
We're very close. I don't know if Elizabeth is part of it. Elizabeth obviously is a national expert, international expert on prostate cancer, but there's the VISION trial, which is post-chemo, which the technology is so cool. So you're taking it's called Theranostics. It's this whole new exciting space of where we're taking a low dose radiation and bolting it to the PSMA molecule. So this little molecule knows and finds the prostate cancer and delivers a little radiation to it. It's called lutetium, and there's another marker out there. But Elizabeth, I don't know if you guys have VISION trial, but this is we're close. I mean, there's phase 3 trials going on right now.
Yeah, it's an interesting concept with PSMA, because when you talk about the imaging, it's usually attached to gallium-68, and you'll see that it literally says GA68 and then the PSMA. The field that you aptly referenced to as Theranostics is sort of the hot new topic in cancer, only because just logistically it makes sense to us. Oh, there's a little flag of this molecule, and I'm going to go hunt down that flag, and then I'm just going to kill that cell. So there's an idea that maybe it won't be so toxic because it's only going to go after the cell that you really want to tackle. There are many tracers to PSMA, so you just have to imagine the PSMA is just a little flaggy thing on the cell, but it's got a lot of partners. So the VISION trial that Jason was talking about, the compound that's toxic to the cell is called lutetium-177. So it's Lu-177. So many people know that. That trial's been closed now for many, many months. The readout probably won't be until late next year. And there are very specific parameters of the readout. So we're all kind of holding our breath, and we hope for good news, but you don't know. And that's the thing about a trial. We appreciate when people participate because it can make these kinds of differences. I want to put out there, though, there are other PSMA molecules in trials. So not just lutetium-177. The folks at Cornell have actinium-225, so that's AC-225. So that's just a different molecule that's going to try to kill the cell. But then there's a whole new wave of PSMA partners, and we call them BITE-specific antibodies. So they're little PSMAs that are tagged to little other markers that can either be an injection on the skin or an IV treatment, but many centers now, including ourselves, have those. So it's still a PSMA targeted drug, but the way to kill the cell is a little bit different. And then ultimately, I think what everyone is sort of holding their breath for is CAR T cells. So many in the audience may have heard about CAR T cells because they're already active and in use for those with leukemia and lymphoma, but they really haven't crossed over to what we call solid cancers. But that's something in the works for 2021 for prostate. So again, some of them have attached itself to PSMA and some of them have not, but it's a way to try to kill the cell that's very prostate specific. So if you can get on a clinical study, whether it's here or elsewhere, that's a huge contribution to move the field forward.
And I think the value for clinical trials and what I talk with my patients, it's the highest quality of care that you can get. These trials are mostly, FDA trials, so it's run through the government or these large national co-ops, and they're very rigid. Nothing gets missed. Labs have to be done on time, scans have to be on time, and frequently the scans are read by national experts. They're blinded to the clinical condition. One of the values of these clinical trials, not only are you potentially getting, the future therapies, which may or may not work, we really don't know it, but you are still getting truly the highest level of clinical care you can get, because, as an investigator, it's me and my team of researchers, but also behind that, everything that we do is reviewed by, multiple people that know your situation, may not know your situation. And it's just such a benefit to getting this quality of care that you can't get or even deliver, honestly, in everyday clinical practice, because, you don't have that framework to work through.